Welcome to the deep dive. Sometimes the most common conditions are the ones we maybe don't fully understand.
That's often the case.
And today we're tackling one of those spermatoceles, or you might know them as spermatic cysts. Lots of men encounter them, but maybe aren't quite sure what they are.
Exactly.
So our mission for this deep dive is pretty straightforward. Give you a really clear, high-yield overview. We're focusing specifically on effective revision, drawing directly from our spermatocele clinical notes.
Sounds good. We'll cover everything you need.
Yep, from the definition, the causes, risk factors, all the way through to, the rare complications. Basically, a solid revision session based on those notes, ready to jump in.
Absolutely. Let's get started. Given how often you might actually come across spermatoceles,
Yeah.
having this clear understanding is, well, it's key.
Okay, so definition first. What exactly is a spermatocele according to the notes?
Okay, so fundamentally, it's a fluid-filled cyst, and it forms specifically in the epididymis.
Right, the epididymis, that coiled tube behind the testicle.
Precisely. And the key characteristics, the things you really need to remember from the notes. These cysts contain sperm. They're almost always benign, non-cancerous.
Okay.
And importantly, they're typically painless and feel, quite distinct, separate from the testicle itself.
Got it. Sperm-filled, benign, painless, separate. The notes mention potential causes.
Yes, they point to a couple of things. One is a blockage in the epididymal ducts, the tubes within the epididymis.
Makes sense, like a plumbing issue.
Kind of, yeah. Or, interestingly, a history of vasectomy is also mentioned as a potential link.
Oh, okay. And who gets these most often?
The notes highlight middle-aged men as the most common demographic.
Right. So maybe a memory tip? Spermatocele, like sperm contained in a cell or cyst, specifically in the epididymis.
That works. Connects the name directly to the location and content.
So we mentioned blockage. Is that definitely the cause, or is it more complex? What did the notes say about the etiology?
Well, that's where it gets a bit less certain. The notes are clear that the exact cause isn't fully understood.
Ah.
But the main theory, the one the notes emphasize, does point strongly towards that blockage or some kind of obstruction in those epididymal ducts.
Right.
And that blockage stops the normal flow of fluid and sperm, causing it to back up and form the cyst.
Okay, so blockage is the front-runner theory. Anything else mentioned?
Yes, the notes also suggest that inflammation or maybe even some past trauma to the epididymis could potentially play a role in some cases. Not the main theory, but a possibility.
So blockage is likely, but maybe inflammation or an old injury could be factors too.
Interesting. Now, are there things that make someone more likely to develop one? Risk factors?
Yes, definitely. The notes list several specific risk factors to keep in mind for revision.
Like what?
Okay, so a history of previous scrotal surgery is one.
Makes sense. Could disrupt things down there.
Exactly. Also, any previous epididymal infection or inflammation epididymitis?
Right. That links to the inflammation point.
It does. And then, perhaps more surprisingly, certain underlying conditions are mentioned. Things like cystic fibrosis. Cystic fibrosis?
Yeah.
Really? How's that connected?
Yeah, it's an interesting link mentioned in the notes. Also, congenital abnormalities of the reproductive tract. So, problems someone might be born with.
Okay, so surgery, infections, and these underlying conditions like CF or congenital issues, that's quite a mix. Is there a quick way to remember those for exams? A mnemonic, perhaps?
We could try one. How about SCU?
SCI. Let's hear it.
Okay, S for scrotal surgery, E for epididymal infection or inflammation.
Yeah.
For underlying conditions like the CF or congenital issues.
And you.
Well, the U is maybe a bit of a stretch, but we could use it to remember that the cause is often unclear or linked to these underlying factors. It loops back.
SCIU, surgery, epididymal issues, underlying conditions, unclear cause. I like it. It hits the main points from the notes. Okay, so pathophysiology was happening on a sort of micro level.
Right. The pathophysiology, as the notes explain it, really boils down to that obstruction in the epididymal ducts we keep mentioning.
Blockage again.
Yes. It disrupts the normal outflow fluid and sperm buildup behind it, and that forms the cyst. The notes mention they often start small.
And often unnoticed initially.
Exactly. Frequently asymptomatic at first.
Yeah.
But the key thing pathologically is that they can slowly enlarge over time as more stuff accumulates.
A gradual buildup. Okay. Now, differential diagnosis. This sounds crucial. If someone presents with a lump, what else needs to be considered besides a spermatocele?
Absolutely critical. You have to differentiate it. The notes list the key differentials you need to know.
Let's list them.
Okay, first, a hydrocele. Remember, that's fluid around the testicle, not in the epididymis. Different location.
Hydrocele. Okay.
Then, other types of epididymal cysts, maybe ones that don't contain sperm. Also, a varicocele.
Varicocele. The enlarged veins, right? Feels different.
Yeah, often described as feeling like a bag of worms, quite distinct on examination. And then, the most important one to rule out.
Let me guess. Testicular tumor.
Precisely. Testicular tumors, ruling that out is paramount.
So, hydrocele, other epididymal cysts, varicocele, tumor, maybe a mnemonic for those two, HEVT.
HEVT, hydrocele, epididymal cyst, varicocele, tumor. Yeah, that works. Simple and covers the big ones from the notes.
Okay, HEVT for differentials. Now, how common are spermatoceles actually, epidemiology-wise?
Well, the notes mention that specific UK prevalence figures aren't readily available, but they're generally considered relatively common.
So not rare.
Definitely not rare. And they can occur in men of any age, though. As we said, most frequently identified in middle age.
Right. So clinical features. What does someone actually experience, or how is it usually found?
Well, the most common presentation, as the notes highlight repeatedly, is actually nothing. They're asymptomatic.
Found by chance.
Often, yes. During a routine checkup or maybe imaging for something else entirely.
But if they do cause symptoms...
The classic symptom is a painless scrotal swelling or lump, sometimes described as a feeling of heaviness in the scrotum.
Just a lump or heaviness, usually painless.
Exactly. Less commonly, the notes mention some men might report more persistent scrotal heaviness or even a constant dull ache. But sharp pain is unusual for an uncomplicated spermatocele.
Okay. And on examination, what's the key finding?
The key finding is palpating that smooth, often quite mobile, fluid-filled mass. And critically, it's usually located in the upper part of the scrotum, posterior to and distinct from the testicle itself, usually the head of the epididymis.
And you mentioned a way to potentially differentiate it earlier.
Ah, yes, transillumination, the flashlight test.
Tell us about that again.
So, in a dark room, you shine a bright light through the scrotal swelling. Because a spermatocele is filled with fluid, the light should pass through it. You'll see a reddish glow.
And solid masses.
Solid masses, like tumors, won't transilluminate. They block the light. It's a simple, useful clinical sign mentioned in the notes.
Very useful bedside clue. Okay, investigations. How is the diagnosis confirmed? Is the exam and transillumination enough?
While the clinical exam and history raise strong suspicion, the definitive confirmation usually comes from imaging.
Which imaging?
Scrotal ultrasound. It's the primary investigation listed in our notes.
And what does ultrasound show?
It gives a really clear picture. The notes specify you're typically looking for a well-defined, often small, maybe 1 to 2 centimeters, hypoechoic lesion.
Hypoechoic.
Meaning it appears darker on the ultrasound screen than the surrounding tissue. Ultrasound is also excellent for confirming it's cystic, locating it precisely in the epididymis, and crucially, ruling out other issues like testicular tumors.
So ultrasound is the gold standard here.
Yeah.
Management. Once it's diagnosed, what happens?
It really comes down to symptoms. As the notes state, if the spermatocele is asymptomatic, not causing any bother.
Just leave it alone.
Pretty much.
Yeah.
Observation monitoring is the standard approach. No treatment needed usually.
But if it is symptomatic, causing pain or discomfort,
then you consider treatment. The main option discussed in the notes for symptomatic cases is surgical removal. That procedure is called a spermatocelectomy.
Spermatocelectomy, okay. What about pain relief if surgery isn't done immediately?
Simple oral pain relief, like paracetamol or ibuprofen, can be used if needed for mild discomfort, as the notes suggest.
And those other treatments mentioned, aspiration, sclerotherapy?
Yeah, the notes mention aspiration, draining the fluid with a needle, and sclerotherapy, injecting something to scar it down. But they also emphasize these are rarely considered first-line options.
Why is that?
They often have high recurrence rates, the fluid just comes back, and they carry their own risks. Spermatocelectomy is seen as more definitive if treatment is needed.
But surgery isn't risk-free either, right? The notes mentioned caveats.
Correct. Spermatocelectomy, while generally effective, isn't always a perfect fix. There's a small risk of recurrence, and importantly, a risk of damaging the epididymis during the surgery.
Which could affect fertility.
Potentially, yes.
Right.
Which is why it's a particular consideration for younger men who haven't completed their families. It's a discussion to have.
Understood. So weighing the symptoms against the risks of intervention, what about the overall prognosis, long term?
Generally excellent. That's a key takeaway from the notes. Good to hear.
For asymptomatic ones managed by watching and waiting, they often just stay stable. If surgery is done for symptoms, it's usually very successful at relieving those symptoms.
And do they come back often after surgery?
Recurrence after surgery is rare, according to the notes, so generally a very positive outlook.
Excellent. Any serious complications to be aware of?
Well, the notes stress that spermatoceles are typically benign and complications are rare.
But not zero.
Not quite zero. In very uncommon cases, the notes mention the possibility of infection developing within the cyst or even forming an abscess.
And that would need treatment.
Oh, yes, that would require prompt medical attention, likely antibiotics, possibly drainage. But again, this is emphasized as being rare.
Okay, rare but possible infection. Good to know. Right, let's go ahead and summarize the key points from this deep dive based on those clinical notes.
Sounds good.
So, spermatoceles, fluid-filled cysts, they contain sperm located in the epididymis behind the testicle, usually benign and painless, often found incidentally, especially in middle-aged men. Key cause thought to be duct blockage.
Diagnosis relies on clinical exam, looking for that separate, smooth, trans-illuminating lump confirmed by ultrasound. Remember, HEVT for differentials.
Management is typically observation if asymptomatic. Surgery, spermatocelectomy, is symptomatic, bearing in mind the risks.
And the prognosis is generally excellent, with complications like infection being rare.
That covers the essentials from the notes nicely.
Perfect. Which leads us to our final provocative thought for you, the listener. Given how common spermatoceles are and that they're often found by chance, it really makes you think, doesn't it?
It's about them.
About the role of regular testicular self-examination, not necessarily just to find spermatoceles, but more broadly, fostering that awareness and familiarity with one's own body. Could that habit lead to earlier detection of other things, perhaps more serious conditions?
That's a really important point. Promoting that kind of health awareness and self-familiarity is definitely valuable. Food for thought, indeed.
Absolutely. And for those of you revising for your MSRA, remember to check out passthemsra.com and also freemsra.com for more high-yield resources.
Great resources for revision.
Thanks for joining us for this deep dive into spermatoceles.